Good evening, everyone. On behalf of Intas Pharmaceutical Limited, I, Dr. Mithilesh Nayak, welcome you all to this ninth episode of Endocrine Talk Show. And today we are going to discuss about the role of combination we can manage our diabetic patient better with the use of combination OAD. And to give us a valuable insight, we are having with us Dr. V. Mohan sir. And to moderate today's session, we are having with us Dr. Subhankar Chaudhary sir. He is a professor and head at Department of Endocrinology at SSKM Hospital, Kolkata. And he's a well-known endocrinologist. So without further ado, I hand over the digital podium to Subhankar sir and request him to introduce our uh, speaker and panelist for today's program. Over to you, sir.
Thank you very much. A very good evening and maybe a belated Happy New Year to all of you. I think we have a very well-known speaker and panelist this evening. And they are known to all of you. Nonetheless, it's customary that I do introduce, and I have great pleasure in introducing this evening's speaker, Professor V. Mohan, who has so many accolades to his name. He is won the prestigious B.C. Roy Award from the Medical Council. He has had the Dr. B.R. Ambedkar Centenary Award. He's won the Harold Rifkin Award from American Diabetes Association. He's also been awarded the prestigious Padma Shri by the Government of India in 2012. He has an unbelievably large number of publications, more than 1,100 publications, and he's prolific in his research work. So the main research interests are epidemiology of diabetes and its complications, and also genomics of diabetes and fibrocalculus pancreatic diabetes. He is, of course, chairman of Dr. Mohan's Diabetes Specialty Center and president Madras Diabetes Research Foundation in Chennai. So it's over to, and of course, we have two excellent panelists this evening, Dr. Manoj Chadda, a very senior consultant endocrinologist at Hinduja Hospital in Mumbai. He is the immediate past president of the Indian Society of Bone Mineral Research and a past president of Endocrine Society of India 2017-2018. And he is a very well-known speaker at national and international fora. We also have Professor Nilanjan Sengupta, who is professor and head Department of Endocrinology at NRS Medical College in Kolkata. He's the Honorary General Secretary of Endocrine Society of Bengal. He is also an associate editor of the Indian Journal of Endocrinology and Metabolism, and he also has numerous publications to his name and a very distinguished speaker at different conferences across the country. So we welcome all of you, and we welcome all our participants this evening. We have a very important area to consider today, the combination therapy in type 2 diabetes. And this is one area, I think, where India has led the world. We came up with more combinations earlier than anywhere else in the world, and possibly we have more combination fixed dose combinations than any other country. So what we have planned this evening is, first of all, maybe have a brief presentation providing an overview of this area of combination treatment in type 2 diabetes. And we are covering for now the hyperglycemia part of type 2 diabetes. And that will be delivered by none other than Dr. V. Mohan. And then we shall have all of them, Dr. Mohan, Dr. Chadda, and Dr. Sengupta. I don't see Nilanjan has joined yet, but I'm sure he will join in good time. And we will then have a good discussion. So I would request all of you to post your questions. Those get the precedence. Only if I don't see enough number of interesting questions in the chat box, then maybe I'll be forced to ask some questions on my behalf. So let's hope I put in less questions and you provide the queries that you all have. So over to you, Dr. Mohan. It's always a pleasure to listen to you, to interact with you.
Thank you, Professor Shubhankar Chaudhary. Let me first get my slides. Is it seen? The slide seen or?
Yes, sir.
Yes,
sir.
yes. And you heard. Yeah.
Thank you. So let me thank Intas Mitlesh and team for inviting me to give this talk. I think it's very important. And as Professor Shubhankar Chaudhary just said, India is really a world leader in combination therapy. I remember 1998 or so, some 24 years ago, when we organized the first ADA postgraduate course at Chennai. It's the first time that the ADA was coming out of US to India to do this course. And we had the president of ADA and the secretary and everyone come. And when they went around the stalls in Chennai where we had organized this meeting, they saw so many combination therapies. And they said, this is amazing. I'm talking about 25 years ago, where they said, it's amazing. We don't have a single one of these combinations in the US. And they got their first combination so much. In fact, they got the metformin itself only just before that, only 95 or something, they got the metformin. So in many ways, I think the India pharma industry is far ahead. And also we bring these drugs so cheap that I think we supply a large percentage of the world's oral drugs. So it's very appropriate that we discuss this. And today, we have so many combinations that it's worth discussing that as well. Go to the next slide. So this is just by way of introduction that we have a huge burden of diabetes in India, something like 74 million people, almost 1 in 10 adults. And these numbers are going up. In fact, we have a paper in press in Lancet Diabetes Endocrinology. It's still under review, and we're hoping that it gets accepted for publication, where we are doing some projections and using the INDIAB study. And it's probably much more than the 74 million that we're talking about. It's probably closer to 90 or 95 million people that we have in India, but that's not yet published, so we won't go into that. The official figures are still 74 million people. Now, there are a lot of challenges in the treatment of diabetes. And one of the things is that it's so heterogeneous that there's no one size fits all. And then you add to that, you have the cost of therapy, the A1Cs, which get more and more difficult to control over time. And then you also have hypoglycemia, obesity, CVD, compliance. All these issues are there, which we'll consider in greater detail. Now, if you look at glycemic control, it remains a major challenge in India. And if you look at this paper, which we published some years ago, from the Diet Care India study, I think it was 2011, about 11 years ago, 12 years ago, when he published this. And at that time, the mean A1C was 8.9 plus minus 2.1 across these top clinics. You can see the big names here. All the who is who of diabetology and endocrinology in India are there. And in their clinics, if you take the mean A1C, it was close to 9, which is horrendous. Of course, you may say that the worst patients are going there because they are famous doctors. The worst patients get referred there. So you will have to do population-based studies. Otherwise, you really can't conclude from this clinic-based data, which is subject to referral bias. That is absolutely true. And that's why we have the INDIAB study. So in the INDIAB study, this is an early INDIAB paper, 2014 or so. Now we have completed INDIAB. The entire country is over. And when we completed this first 4 states, we just looked at the control of diabetes in these 4 states, Tamil Nadu, Maharashtra, Chandigarh, and Jharkhand. And what we found was that if you look at A1C less than 7, this is urban and rural. Green is urban and the orange is rural. Only 30% had an A1C below 7. And if you look at the other end of the spectrum, poor control, A1C more than 9, almost 40% of the rural and 32% of the urban had A1C above 9. Okay, and this is 2014. I'm sorry to tell you that now when you completed INDIAB, in the more recent states which we have studied, including West Bengal and Kerala and all the other states, it remains the same. There doesn't seem to be any gross change in the A1C values, and the challenge is that the control remains suboptimal throughout the country. And this is representative sample of the whole country. You can't say that there is any bias in this. Now, we also know that if you have poor control, the complications start going up, whichever complication you name it, and the higher the A1C, the greater the complications. But the question arises, why is the glycemic control poor? Now, one of the reasons is that we use this sequential approach. And this is something which we have all been trained in, and this is what we do. We first try lifestyle, knowing very well that it won't work. When A1C is 9 or 10, you go and just give lifestyle to them. It's not going to work. But then what happens is very, reluctantly, patient also doesn't want, no, don't give me any drug, the patient will say. Doctor will also say, okay, let me try one metformin for you. We'll see what. And if the A1C is 11 or 12, how is one metformin going to work? We don't even realize that. And then we start off. That's what the verified trial showed, where, 2 drugs together given as initial treatment work much better. But what we do is we give one drug, then we wait for 17 months before adding a second drug. Even if the control is poor, almost 1.5 years goes before we think of a second drug. And then 31 months goes before you add a third drug. So you can imagine already so many years have gone, and the early control that we talk about, the legacy effect and the metabolic memory, all this is very bad because the control is so bad. And yet we hesitate. Why should we give one more? Can we give? The patient also doesn't want. We also don't want. So this is what happens. Now this is what is represented here in a cartoon form, that even if you have achieved the A1C of 7%, it's a moving target. So after 6 months, 1 year, the A1C will go up. And patients, once they reach 7%, they think they have achieved everything. They don't have to come back and see the doctor. They think we're just asking them to come back to make money out of them. So what happens is they stop coming. So this is just a hypothetical graph, but we have data which we have published to show that this is exactly true. So it is not something which is made up. So if you wait, the longer you wait, the A1C will go up. So let's say the patient took 2-3 years to come back to us. All this glycemic load or glycemic burden, anything above 7, we call it as glycemic burden. And that glycemic burden accumulates. So what is the solution? Solution is to get them back earlier. So if they had come back here, let's say after 1.5 years they came back, then definitely we would have taken some steps to bring it down. Okay, so this part would have been avoided, this glycemic burden avoided. But this is unavoidable because they came only after 1.5 years. What if they came back after 6 months? What if they came back after 3 months or 2 months? Then the unavoidable burden keeps going down, and all this would have been avoided. And that is the most important secret for preventing complications of diabetes. I always tell my patients, if you just come and see us every 2-3 months, we can ensure that you don't develop any complications. Because when they come, we'll also check their microalbumin, we'll check their blood pressure, we'll check their lipids, we'll check their weight, we'll check their adherence, we'll check their diet, we'll talk to them about exercise and so on. That's very important. We'll also probably add another drug earlier as well. So this is called as clinical inertia. This is my own definition some time ago, where we define clinical inertia as a lack of treatment intensification in a patient, not at evidence-based goals for care. So the patient is not at goal at all. That 7% has not been achieved, but still we hesitate. We don't do that. In other words, it's also a failure of the healthcare providers to initiate or intensify treatment when indicated. And this is more, in detail. We've written, expanding the concept of clinical inertia, where we have defined what are all the things you should do to prevent this clinical inertia. And in this paper, also we have we call it as time to do more. We have to do more and just not wait. Laissez-faire attitude, chalta hai attitude. Okay, let's see what happens. Let's say it's another 6 months, 1 year. Diabetes doesn't give us enough time. Once microalbuminuria starts, it'll just keep going down. So we have to be proactive and try to prevent this. The other problem is adherence and the pill burden. Okay, remember that it's not just the diabetes pill that a person with diabetes takes. There's also blood pressure pill. Then there's a statin. Then there could be aspirin. Then there could be other things that they're taking. Maybe B12, maybe vitamin D, maybe something else. So they're going to have riddled with this. And that is the objective of today's meeting, that we have fixed drug combination, then it will be better. Often, when you put these into a single pill, the cost actually comes down. Whereas if you take it separately, it's unaffordable. Now, these are some data from India actually to show that the daily bill burden was about nearly 4.6 plus minus 2. So an average person with diabetes is taking some 4 to 6 pills a day, and the average cost of the treatment is also very high. But if you use generic drugs, of course, the cost comes down. Now, here is another study which is showing that taking a fixed dose combination can lead to significant improvement in adherence. It makes sense. If you have to give sulfonylurea and metformin, or a DPP4 and metformin separately, that becomes 2 or 3 drugs immediately. Whereas you put it together, it becomes 1 pill, and the patient doesn't feel that he's taking or she's taking too much of treatment. Now, in the US, as I told you, so I told you 1998, they came to Chennai for the first MDRF ADA postgraduate course. At that time, they didn't have a single FDC in the US, not even one, not even a combination of sulfonylurea and metformin. And that time they were seeing so many combinations in India, they were kind of, completely flabbergasted. And they were saying, what is this? In India, you have so much advanced than us. We don't even have. Their first glucovans, or combination of glibenclamide and metformin, came only in 1999. Imagine 20 years before that itself, we had these combinations. As you can see, 1970, we had a combination of penformin and chlorpropamide. Then glucored, that is combination of glibenclamide. Why I'm telling you these trade names, sometimes you will not know what it contains, but the trade name might have registered in your mind. And then we had glipizide plus metformin combination, glibenclamide plus metformin. All this is already available when they came to India, and they were seeing all these combinations. Now, these 2 drug FDCs, today it is accepted globally, and almost all the countries, including the US, have these 2 drug fixed dose combination. In India, there's been some reservation of going more than 2, but if absolutely indicated, I think 3 drugs are being approved by the Drug Control of India. So we can call it as Indian innovation, Indian pride, that the FDC combination is going on. In fact, the concept of polypill also came not from India. The concept is not from, but the first polypill trial, if you have seen our Lancet paper with Dr. Salim Yusuf, where I'm also an author in the main Lancet, where we did the polypill trial. It's called TIPS, the Indian Polypill Study, or TIPS for short. That was done in India. It was not done in US or Europe or anywhere. And we then came Hope 3, and so many other trials have been done with Salim Yusuf and Dennis Xavier and others. And so we have many triple drug FDCs available for coronary artery disease as well. Now, here is a study where Sanjay Kalra, and maybe some of you are there in this as authors, and they actually showed, an expert opinion from the international panel, they showed that simpler dosage improves therapy, reduces pill burden, reduces medication errors, and allows synergistic combinations to be used. Costs come down. Many advantages were reported in this paper. So Indian pharmaceutical companies have introduced triple drug combinations. We have already had sulfonylurea, metformin, pioglitazone, and when we had the pioglitazone controversy, in fact, the government and the DCGA said, don't bring triple drugs with pioglitazone, because people did not even know what these triple drugs contain. So they would write pioglitazone separately, then they'll write pioglitazone with metformin, then they'll write another one with 3 drugs. And so I've seen people taking 3 pioglitazones of 3 different brands together and so on. But the point is that if you take 2 or 3, sulfonylurea, metformin, voglibose, these kind of combinations help in reducing the pill burden definitely. Now, of the available triple drugs in India, FDCs, there are many, and probably this list is incomplete. So we have glimepiride, metformin, pioglitazone, glimepiride, metformin, voglibose, we have remogliflozin with vildagliptin with metformin, plus many others which have come now and which I'll share with you. So it's been shown to be effective. The pharmacokinetics has been shown to be good. But then when these old drugs were there, we were not talking much about decreasing cardiorenal risk or weight gain. We're only concentrating, as Dr. Shubhankar Chaudhary said, on the glycemic part, the HbA1c. We are not worrying about the B and the C, the blood pressure, the cholesterol, and also we're not worrying about weight, renal safety, renal improvement, cardiac improvement, heart failure. All these came more recently. And of course, hypoglycemia. Any of the drugs with sulfonylureas will be more prone to hypoglycemia, obviously, isn't it? So, and hypoglycemia we know is a big problem, and we don't have to go far. When you look at the Accord trial, where they tried for tight control, A1C of 6%, and you know the number of deaths that they had, and 257 in the treatment arm, and the study had to be stopped So whether it's hypoglycemia is a cause of the death, we don't know, but certainly there were deaths. Now, but we do know that hypoglycemia produces cardiovascular events, can trigger cardiac arrhythmia, can trigger myocardial ischemia. All this you know very well, that if you have severe hypoglycemia, the incidence of these is in the leader trial. In any trial, the more hypoglycemia you have, the more cardiac events you have. So what is next? We must consider safer options in combination where you don't get hypoglycemia and you still get all the other benefits. One more thing which has emerged today is obesity, because obesity is increasing very rapidly in India. And we know that there are certain drugs, for example, the TZD group, insulin, and to some extent sulfonylureas, all these can increase the weight of the individual, which you don't want in somebody with type 2 diabetes. Why do you want the weight to go up? You want the weight to come down, isn't it? Now, this is just to show you the INDAB results in various states of the country, where you can see that if you look at the prevalence of obesity, it's huge. This is abdominal obesity. And you can see in urban India among females, almost 60%. This is not among diabetic patients. This is the whole population in India. 60% of the women in urban areas are obese. And in men also it's about 40%. Rural areas slightly lower, but almost 42% of women in rural areas are having obesity, and almost a quarter of the men in rural areas having obesity. And these numbers are only going up. 10 years later, it will be much more than this. Okay, so obesity is a huge problem. So if you have any drug which reduces the weight, that's very good. Now, we also know that obesity is linked to pre-diabetes as well as diabetes. So if you have underweight people, most of them will have normal glucose tolerance. What is shown here is the normal glucose tolerance. Then you have the IFG, and then the blue here is diabetes. So if you look at those who are underweight, virtually no diabetes. As you go to normal BMI, diabetes is not much. The top one is, the blue one is diabetes. You can see 3%, 4%, 7%, almost 10%. Look at pre-diabetes, 17%, 24%, almost 30%, almost 36%. So as obesity increases, you're going to get a lot of diabetes and pre-diabetes that you all know. Okay. What about cardiovascular risk? Now we know that addressing cardiovascular risk is very important. Here is a study again where many of you might have been involved in this, and led by Dr. A.G. Unikrishnan as first author, where they show that among the newly diagnosed patients in India, almost 39% were classified as high risk for CVD, and 60% were classified as very high risk based on the Lipid Association criteria. So cardiovascular risk is a genuine risk. In fact, a lot of people who say that diabetes is a cardiovascular risk equivalent. So if you have type 2 diabetes, you already have like cardiovascular disease. And that's why when the ADA and the EASD came out with the guidelines, earlier, about 5 years, 6 years ago, you know, they used to just have metformin on the top. And then they said anything else. You can use sulfonylurea, you can use pioglitazone, you can use DPP4, SGLT2, GLP-1 receptor analog, or even insulin. Anyone, you choose, like a lottery, you choose anything. Now it's getting much more personalized, much more precision oriented. So they say, okay, if you have heart failure, then you should use SGLT2. If you have atherosclerotic heart disease, then GLP-1 or SGLT2. If you have CKD, SGLT2 comes out right on top. So now definite guidelines are coming to an extent that if you don't use them, people will probably question you now. Why is this patient having proteinuria, and why haven't you given a SGLT2? Why haven't you given patient has a risk of heart failure? Why haven't you given SGLT2? Now that's the stage we are in now. So which FDC to choose from? Now, you know that, the ominous octet and now the deleterious dozen, and there are so many defects in type 2 diabetes. You have the beta alpha cell defect, you have beta cell defect, you have amylin defect, you have adipose tissue, skeletal muscle, liver defect, even in the brain, incretin defect, immune dysfunction, then in the stomach, absorption, and kidney, the reabsorption of glucose, plus there is inflammation and so on. So something like 8 to 12 defects you have in diabetes. How are you going to cover all these if you just give one metformin? It doesn't work. Just before we started this meeting, I was saying that in IFG, impaired fasting glucose, metformin could not even prevent the progression to diabetes, in those with impaired fasting glucose, IFG. So you need obviously more drugs, at least 2. And if necessary, if the sugars are very high, then even maybe 2 or 3 drugs may be needed to control the diabetes. And so the rest of the talk, I must admit that this is a INTAS lecture, and where the specific focus is on their molecule, metformin, sitagliptin, and dapagliflozin, which they have brought and other companies have brought as triple drug, fixed drug combination. So we're going to, and it's a fantastic combination, no doubt about it. We know metformin. In sitagliptin, one of the best DPP-4 inhibitors, and dapagliflozin, a top class SGLT2. So let's quickly review the evidence of these 3 and using them together, and then we'll go to the questions. Now, we know that when you use triple drug combination, for example, instead of using sita and metformin alone, if you sita plus dapa plus metformin, you get a much greater reduction in the A1C level, obviously, because you're using different pathways and you're covering more of those 8 to 12 defects. Look at fasting blood glucose with the sita and metformin alone. If you get that much reduction with one more drug being added, it is much more, and that is statistically significant as well. Postprandial blood sugar reduction, same thing. If you look at hypoglycemia, that's the beauty of this combination. None of the 3 by themselves, metformin, sitagliptin, or DAPA, none of them really produce hypoglycemia. And if you put them all together, only 2% have hypoglycemia. If you replace one of this with a sulfonylurea or something else, you will get fantastic hypoglycemic episodes. Here, it's very, very low. Now, let's go on to DAPA. And this study is if DAPA is added on to sitagliptin. So what do you get? It's a randomized clinical trial. And the conclusion is that the safety profile of these is very good, because the very low rates of hypoglycemia and hypovolemia and so on is very low. And here again, you can see that when you use a triple drug combination, you are getting much better effects as far as the weight is concerned, as far as the glucose lowering is concerned. What about the cardiovascular protection? All the 3 components have established cardiovascular safety. May not be beneficial, but at least they are safe. We know from TCOS that sitagliptin is a very safe drug. We know from the declare-TIMI that dapagliflozin is actually beneficial, very good for the heart. And metformin, from all the studies, at least it doesn't do any harm. Whether it produces any good or not, we don't know. Certainly, it doesn't produce any harm. So let's look at some of these sitagliptin. But before that, I'd just like to step back and say that not only they are cardiac safe, but these drugs, the DPP-4 inhibitors in general and sitagliptin in particular, this is a paper which we published in 2009. So several years ago, almost 14 years ago. This is the first study of sitagliptin before it was introduced, and I happen to be the first author of that, where we showed that if you look at the response of the Indians and Koreans to sitagliptin, you find that the A1C reduction is much more in India and in Korea, little less in China. China, this reduction was the same as you get in Europe. So in Europe and US, they say it's a very mild drug. You get 0.5% reduction, like with alpha glucosidase inhibitors. But we found that you're getting a significant reduction. At least 5 or 6 other studies from Korea have confirmed this. At least 3 or 4 other studies from India have confirmed this. My good friend, Dr. Avdesh Singh, A.K. Singh from Calcutta, has written reviews on this, showing how the incretin group of drugs are better in Indians and so on. In 2020, we did a complete meta-analysis systematic review. Our PhD student, Shushima Gan, and along with the University of Dundee, we published this, and we reviewed the white population as well as the Asian population with respect to DPP-4s, SGLT2s, and GLP-1s. And what we found was, for the first time, we showed that the SGLT2s also work better in Asians compared to the white population, and the DPP-4s also. So 2 of these drugs, SGLT2 as well as DPP-4s, seem to work better in Asians. In fact, there was a review, there was an editorial written on this article by Diabetes Care, praising this and saying how well the meta-analysis was done and so on. Now, if you look at TCOS, and this is old data, so I'll rush through that. The point about TCOS is that it was absolutely safe as far as the primary cardiovascular outcomes, as far as the secondary cardiovascular, hospital and heart failure, death from any cause, no different from placebo. This is what the FDA wanted, isn't it? Safety. That's why it's called cardiovascular outcome trial, CVOT. So TCOS was an excellent example of how it was exactly in the middle, and there was no safety issues at all. Now, if you take DAPA with declared Timmy has shown that it is actually beneficial for the heart, and it's one of the largest and longest CVOT trials. And you can see that particularly with reference to hospitalized from heart failure and CV death, there was a significant improvement, a hazard ratio of 0.83 compared to placebo, 17% reduction in heart failure and CV deaths, which is significant, highly significant, and 14% reduction in MACE as well. So here is a drug which is going to be beneficial for the heart. And the other one, sitagliptin, is neutral for the heart. Okay. And what about metformin? Well, we have been using metformin for the last 60 years, and we all know that if anything, it actually reduces the CV mortality and all-cause mortality. We're not saying it's a cardiac-friendly drug or cardiac protective drug, but at least it doesn't do any harm, and maybe it will do some benefit because of its weight lowering and the glucose control and so on. So when we use this multiple drugs here, we know about the ominous octet and so on. You can find that the DPP4 inhibitors and the SGLT2s, when you add, you're covering at least 6 or 7 out of these 8 defects that we talked about in diabetes. And therefore, in summary, ladies and gentlemen, there are significant challenges in the long-term management of type 2 diabetes. Unlike a statin which is given for LDL cholesterol, give a statin, it just comes down. That's it. It's as simple as that. I say that treating LDL is the easiest. Blood pressure, a little bit more difficult. Diabetes, the hypoglycemia, most difficult, because there is a progression, because beta cell function keeps going down. So this leads to poor glycemic control, hypoglycemia, big problem, obesity is a problem. Today we have to consider the CVD risk, and the adherence also is a very important point. Pill burden is a huge burden. People don't like to take that many, the whole palm full of medicines. They feel depressed because of that. And of course, cost is an important one. The FDCs of Indian innovation I talked about, we are clearly the world leader in fixed drug combination. But you'll have to take the right fixed dose combination. The pharmacokinetics has to be looked into, the pharmacodynamics has to be looked into, and the suitability of these drugs working together, the complementarity and the synergistic effect has to be looked into. And there is no doubt that the FDC, consisting of dapagliflozin, one of the best SGLT2s, with a very nice DPP4. And the advantage is that these have now gone off patent, and therefore they become very cheap. And metformin. Some of these companies make them so cheap that for the half the cost of a original drug, you can get all the 3 drugs now. And then by combining these, you get the benefits of CV protection, renal protection, weight loss, BP reduction, maybe some lipid reduction, as well as fantastic glycemic control, and definitely helps to reduce the pill burden. So with that, I'm going to stop and hand over back to moderator, Professor Shubhankar Chaudhary. Thank you very much.
Thank you very much. As usual, we had a wonderful opening to this evening's discussion on combination therapy, focusing on fixed dose combinations. And Professor Mohan, of course, laid the groundwork as to the need for these and what is available to us in order to help the journey of many of our patients with type 2 diabetes. So let's invite the other 2 panelists whom we have not formally met yet, Dr. Manoj Chadda and Dr. Nilanjan Sengupta, whom we have already introduced. I'm trying to find out any questions in the chat box. So Dr. Mithilesh, kindly put all the questions in the chat box so that all of us can have a look at them. And in the meantime, if I can start with Manoj, we talk about the ominous octet, and we talk of the dirty dozen, and now we have gone to 14 and so on. But do you think beyond insulin resistance and beta cell dysfunction, do you think all the others, the alpha cell defect, the adipocyte, the brain, insulin resistance at the level of the brain, the gastrointestinal tract or the kidneys, do they play major role in the pathogenesis of type 2 diabetes, or these are just incidentally associated, some other abnormalities also found?
Thanks, Shubhankar. I think Dr. Mohan has, very explicitly talked about the progression of type 2 diabetes, the numbers going up every year. I remember as students, early 80s, we were talked of the triumvirate 3 defects, which you mentioned were the main defects. But for example, of the whole lot, we understand that SGLT2 activity is actually upgraded in type 2 diabetes. So when you're using an SGLT2 inhibitor, you're doing something more than just glucosuria. The incretin defect is equally important. So, I mean, I would not say that they're just innocent bystanders. They are contributing to the problem, not as much as the insulin resistance or beta cell dysfunction, but definitely significantly. And the fact that this is a progressive disease, starting with just one drug and then just sitting back and relaxing and letting things take its course, probably today is not the right approach. Dr. Mohan mentioned about the early ADA ESD guidelines where it was stepwise, 1, 2, 3. Today it is maybe 2 or 3 right at the beginning. We're not talking of early insulinization here, but I still think it's something we should not forget, because there are times, when you have a catabolic state, you have a patient losing weight, it may work. I'm not saying that these triple drugs don't work. They're wonderful. My teaching to students has changed over 2 decades, but the early insulin somewhere in the back of our mind has to be kept there.
Right, great. So I come back to Dr. Mohan, and it's in line with what Dr. Manoj just said. We all know there's the evidence, the Verify study, which you referred to. So, but in your clinic, if a patient comes with an HbA1c of 7%, which is possibly not very common, but still they do come at A1c 7%, where, if you use metformin, you most likely will be able to get the A1cs under 6.5. But still, would you or do you use a combination, maybe specifically a vildagliptin, metformin, or something like that, in order to sort of prevent the progression of the disease, so to say?
So thank you, Shubhankar, for that. So the first question is, at 7, will you just use only lifestyle? Tell them you go change your diet, come back, then do exercise. That never works. I mean, even in UKPDS, we know 6% of people responded initially. In the first 3 months in UKPDS, remember, everybody was put on diet and exercise. 6%, that means 94% you're going to fail there. And today's, the presentation is much worse than it used to be years ago because of the junk foods and because of obesity being a big problem. So certainly one drug, definitely I would use. Now, if it is only 7, I may not use 2 drugs, because I think metformin, because diet also plays a role. And so exercise, diet plus metformin will definitely bring it. And also it depends on the age of the patient. Suppose somebody is 30, 35 years old, I would go more aggressive, more gung-ho on that. Whereas if somebody is 65, 70, we call it as mild age-related diabetes, MARD. You don't have to hit them so hard. They're not going to develop complications in their lifetime. It's unlikely that they're going to develop kidney disease or retinopathy or neuropathy in their lifetime. So we don't have to hit so hard. So it depends on the comorbidities, the age of the patient, and so on. But certainly, at least metformin will be used for everyone. And if it's a little more, let's say 7.5, 7.8, I wouldn't mind starting with even 2 drugs, which later on, if not needed, you can, because I always believe hit hard and hit early. I think the point which Dr. Manoj Chadha made about early insulin therapy, I'm a big fan of that. Certainly not at 7, but suppose they'd come with 11. I'm not going to give 3 drugs and be happy with it to start with. I'll first give insulin for 1 month and bring it down. Then the tablets will start working really well. I've never needed to use it more than 4 to maximum 8 weeks, 1 shot of insulin. It works like magic. The A1C comes shooting down below 6, sometimes even below 5.6 and all that. fantastic control, which you cannot get with 2 drugs and 3 drugs. Later on, the 2 and the 3 drugs will work, but not initially if it is very high. So it all depends on the starting A1C. It also depends on the comorbidities, age of the patient, everything, and of course the compliance of the patient as well. There are some people who are very, very compliant. There are others. See, I'll tell you one small, incident which it will be of interest to the audience. See, when first we started the glibenclamide, 30, 40, 50 years ago, when we started 1970s, my father used to use quarter tablet of glibenclamide. And I used to joke with him. I was a medical student, and I used to say, what the hell are you doing, taking quarter tablet? You think it works? 1.25 milligram, it works? Actually, it works. Okay. They said, why are you, his sugars are so good. We didn't even have A1C at that time. So blood sugar, everything okay, fine, doing very well. And I say, why are you giving this quarter tablet? Is it more like a homeopathic treatment or placebo treatment that you're giving? He said, no, I disagree with you. Because every time the patient puts that quarter tablet in his mouth, he remembers his diabetes. The moment you stop it, he'll start saying, I don't have diabetes. I don't have diabetes. I don't have diabetes. 3 months after saying that he doesn't have diabetes, he'll forget everything. He'll start having his gulab jamuns and his misti doi and everything he'll start taking. And he'll come back with now HbA1c of 10, 11, and so on. So he used to say, let him take it. Every day, let him take that quarter tablet. As long as he's not getting hypo, why are you worried? He's taking it, he's happy. So let him take it. So I think that is the point, that we should not just tell them, go and try diet and come. It won't work. Whereas they take metformin initially, and also it has this insulin resistance reducing property, which later may help the diet.
Right. So through this story also, a very important lesson that we get is managing diabetes is also about addressing the mind, which
Correct.
is also so very important.
Yeah.
It's not just about writing a few prescriptions.
That's
Yeah.
right.
So we invite Dr. Nilanjan. Maybe he may have missed a little bit of Dr. Mohan's presentation. I don't know.
Actually, he
But,
joined. He joined early. He was there.
Okay. Quietly he's
Welcome,
joined.
welcome.
Yeah. Welcome.
Thank you.
So we because why I'm saying this is because in the early part of its discussion and even before we started formally, we were discussing about India being a leader in FDCs, fixed dose combinations. And I know, because I know you quite closely, that you have your own reservations about the use of FDCs. So would you like to explain why you feel we should not be using more of FDCs?
Well, that's a very bold question to answer. And the reasons are essentially personal, meaning that I feel straitjacketed, means I have to remember so many combinations and so many strengths. And
Okay.
if a patient misses one tablet, then he misses all the 3 tablets. But having said that, if somebody can remember and somebody can rationally use a fixed dose combination, I'm not against it, but I prefer it giving separately.
Right. Good. So we come back to Mohan, Dr. Mohan, and we have a few questions in the chat box. So maybe a quick one. Dr. Fatima wants to know, would you consider DAPA ahead of sulfonylureas in patients with A1C more than 8.5%? Of course, we don't know whether she's referring to fixed dose combination or otherwise. So essentially, if the A1Cs are really high, would you use an SGLT2 or SU?
I don't think, I think we're comparing apples with oranges. If she'd asked me, will you use a DPP4 or a sulfonylurea, because sulfonylurea is more, potent, I think the question would have been more relevant. But comparing a dapagliflozin with a sulfonylurea, I think we are talking about 2 completely different things. First of all, one is secretagogue, one is more like a sensitizer, one is working somewhere else, one your weight goes up, one your weight goes down, one has heart protection, one doesn't have that. So they are actually 2, and why not you combine both? I can even combine a sulfonylurea with a dapagliflozin. Even that is not a bad idea. So I don't think we should directly compare one drug with another drug, and it's not based on the A1C that we decide. Suppose the A1C was high and the person was overweight, and we want that person to lose weight, I will certainly use DAPA as the first choice, no doubt about it. Or if I want to protect the heart, or there's some microalbuminuria and I want the kidney benefit, I'll go for DAPA first. And also depends on the cost. Of course, now the costs have come down, but in the good old days, I would have used a sulfonylurea just because it is cheap and somebody could not afford the other drugs. Today, that problem has kind of gone because these drugs have also become almost affordable for the common man. So I think the question is not whether you use sulfonylurea versus DPP-4. I'd have preferred if the person had asked, suppose somebody is 75 years old, will you use a DPP-4 or will you use a sulfonylurea? Straight answer is I'll use a DPP-4.
Right. So for Dr. Manoj, one of the issues that's raised about the fixed dose combinations, and we also have a Voglibose metformin sulfonylurea, for example, combination. So let's now restrict ourselves to the DPP-4 SGLT2 metformin combination. So when should you advise the patient to take this? Is it before a meal, after a meal? What is it?
Okay, so I just take a step back and continue where Nilanjan left the discussion on combination pills and his pros and cons. I also probably will think along his lines, not because, it's not that I have a great memory and I know all the possible permutations and combinations available in the market. That some of them are very sane, especially the two drug combinations, and the triple drug combinations scare me also. Because like you mentioned, I've seen pioglitazone in 3 different forms in one patient. So that scares me. And then when you want to modify one dose and you have a fixed dose combination, it becomes difficult to modify. So someone is already on separate medications and then you feel, oh, this fits into this particular drug, please go ahead with it. Now, coming to your question, if we feel that we want to start with 3 drugs right away, a DPP-4 inhibitor, SGLT2 inhibitor, and metformin, I confess that I have started using this triple drug combination quite regularly now. I find it very convenient. Those who are in that 7, 8 region and you're starting with 2 drugs, then we could discuss whether you want to go metformin SGLT2 inhibitor or metformin DPP-4 inhibitor. Again, less Dr. Mohan said, depending on the age, the underlying morbidity and life expectancy and things like that. So all said and done, it's good, this triple drug which we are discussing today. Now, when it comes to timing, as the question was, traditionally we've been taught, that sulfonylureas have to be given before meals. Whereas if you see the other drugs, metformin, DPP-4 inhibitor, SGLT2 inhibitor, it doesn't matter. So this particular combination, you can give it after the meal, before the meal, with the meal, it really doesn't make a difference. Only thing is, if you have SU on board, not to confuse the patient, I put everything, before the meals. Otherwise, they'll go back home, they'll send me a mail, they'll send me a message, doc, you said which one before, which one after. Then there's confusion. So if it's only this combination, it doesn't matter. You can give it with your antihypertensives or your other drugs. But if the SU is on board, then you need to give it before meals.
Right. My general preference has been to administer this before meals, but of course it can be given after. And my at least experience has been the metformin traditionally has been given after meals, but at least the slow release metformins, I find it doesn't make a lot of difference.
Unless you have gastritis, then you.
Yeah. So just one more point, whether it is our patients or some of my colleagues also, they feel that with every meal there should be some anti-diabetic going on. Yeah. And आपने दोपहर को कुछ नहीं दिया, yeah, you are giving everything only in the morning. What will happen at night? So that is one thing which needs to be erased, because these are 24-hour drugs. I mean, you can give it once a day. That's the convenience. So it's not only safety, efficacy, the convenience, the economic sense, all put into one drug.
Right. So, Manoj, this is an extension of what is already being discussed. This is Dr. Chaturvedi. He wants to know about when to add a triple drug fixed dose combination, whether you started from the very beginning or first you start on dual and then you go on to triple. So, can you recapitulate? Yeah.
So Dr. Mohan has told us, I mean, we need to remember that each individual drug would get the A1C down by about an average of 1%, let's say, for the sake of discussion. So if you have someone at 9.5, 10.5, and you say, I will go with 1 or I'll go with 2, probably you're wasting time. I would straight go with 3. The conditions apply. There should not be a catabolic state. There should be underlying infection. Again, we're going back to that early insulinization thing. Otherwise, a garden variety diabetic walking into your clinic, short duration, A1C is 9.5, weight stable, I would start with triple drug right away.
Yeah.
Right, great. And I suppose all the other panelists would also agree on this point.
Agreed.
Right, yeah. So, Nilanjan, so this is from Dr. Sandeep Kumar, who wants to know from you the safety of FDC containing DAPA DPP4 inhibitor metformin. You may take it as different separate drugs, but he has asked about FDC. And a related question is, it's often said there's some evidence that if you combine a DPP4 with an SGLT2 inhibitor, then the genital mycotic infections go down. So do you think that's the same experience in real life and possible explanation?
Right, thank you, sir. Generally, as Dr. Mohan has very rightly pointed out, that all these 3 agents, that is the DPP4 inhibitors, metformin, and SGLT2 inhibitors, are by and large safe in well-selected patients. So if on their own they are safe, when you are combining, whether in a single pill or giving separately, they would remain safe. But they have their share of side effects, especially like with metformin, GI intolerance may be there. With SGLT2 inhibitor, the issue of GMI and UTI would be there, and there are set contraindications where you should avoid. So if you avoid those contraindications, if the patient deserves it and there are no contraindications to their use and the treatment is supervised, that should be quite safe. And so far as hypoglycemia is concerned, none of the agents cause hypoglycemia on their own. Of course, if they're added to insulin or sulfonylurea, the chances of hypoglycemia would be more. And so from the hypoglycemia point of view also, they are safe. And while DPP4 inhibitor is weight neutral, metformin is largely weight neutral, may cause slight weight loss. SGLT2 inhibitors can cause weight loss. So on body weight also, the effect is favorable. Coming to genital mycotic infection, yes, there is a hypothesis that has been put forward that when you co-prescribe the 2 agents, the chances of having genital mycotic infections like balanoposthitis or vulvovaginitis probably is less than if you were using an SGLT2 inhibitor alone. And one hypothesis has been put forward is that this DPP4 enzyme, which is present in the yeast or the fungi, is also being inhibited by this DPP4 inhibitor, and therefore that may also give an advantage of not to the host rather than to the fungi. But to me, I think with SGLT2 inhibitor, you will be having glycosuria. If the patient is severely hyperglycemic, the patient will also have glycosuria. If the patient is having glycosuria with an ambient hyperglycemia, that patient has a more chance of developing a genital mycotic infection. Whereas the patient is having glycosuria, which is engendered by an SGLT2 inhibitor, but because of other co-therapies, the overall glycemic status is better, then that person stands a lesser chance of developing or a genital mycotic infection, or even if there is a fungal infection that will tend to be easily treated, maybe self-limited, or will not be a bothersome one. So I think when you are using two agents, the glycemic control also improves rapidly,
Absolutely.
and that also adds to it rather than the hypothesis that has been put forward by the innovative company.
That's
Right.
exactly what I also wanted
there
to
could
say.
be,
Yeah, exactly what I
yeah,
wanted to say.
right. So we stay with Professor Mohan, and we do know this program is sponsored by Intas. We all respect that, but right now we also have a duty to all of us, to all our participants, to be true to science or whatever the evidence suggests. So when we're talking of an FDC, triple drug, SGLT2, DPP4, and metformin, so what are your choices for DPP4 and SGLT2?
So I know it's a very sensitive question in a symposium of this type. But having said that, let's look at the positive side of sitagliptin. Now, sitagliptin, we have clear CVOT data. So we have TCOS. Vildagliptin, we do not have CVOT data of that type, number one. Number two, if you look at sitagliptin versus vildagliptin, Vilda was not approved in the US. The US FDA did not approve vildagliptin for whatever purpose. They did not approve it, maybe because it's a European drug, and European drugs are always difficult in the US. I'm not going to get into that, but it is not used in the US at all, whereas sitagliptin is used in the US. Number three, sitagliptin is a once daily drug, whereas vildagliptin is a twice daily drug. And although now for these combinations, now they are making vildagliptin 100 milligrams and trying to make it OD and all that. All these years we've been using it as BD. So suddenly now we have this OD, and there are some reports I have heard that the OD may not work as well as the BD. I'm not the best expert in that. So given these three, sitagliptin has a slight advantage over Vilda. As far as SGLT2, this is the only one which has gone off a patent. If we leave Remo and all that out, DAPA is the only one. EMPA and all that still have not gone off patent. So we have only one choice as far as DAPA for a fixed drug combination. Sita is an excellent choice. There's no doubt that Sita and Lena are the two fantastic DPP4 drugs, of which Lena has still not gone off patent. And therefore, Sita clearly stands out. But having said that, Vilda has been extensively used in India, and therefore I can't say I have found problems with Vilda, and therefore I prefer Sita. Even if it's a company-sponsored meeting, I would be lying if I did that. So I think it doesn't really matter. There are other combinations with Vilda also coming, triple drugs and double drugs, and all these are coming. I think it all depends on your own choice and your own maybe cost and all other factors taken into account. But there is nothing wrong in saying that sitagliptin is one of the best DPP4 inhibitors, and it's a once daily. And TCOS was a fantastic trial which showed that it had absolute cardiac safety, and therefore this is a very good choice. These three.
Great, thank you. So this is not strictly related to FTCs possibly, but since Dr. Mohan, you are around, we have Dr. Rane wanting to know from you any place of GLP-1 receptor agonists in non-obese type 2 diabetes.
We can. I mean, it's not that it is used only in obesity, because it is a drug which has multiple benefits, as we know. We know it also has CVOT advantages, and weight loss is definitely a big thing. And even if they are non-obese, they may have some abdominal obesity, which GLP-1 would benefit from. But having said that, they're very expensive. And so to give it to a non-obese person with the costs which are currently there, we don't have a generic drug now. And so to give this for a non-obese person wouldn't be my first choice. I would certainly reserve it for somebody who is obese, because that is where because there it will beat the SGLT2 as far as weight loss is concerned. So if I have a really obese person who's trying to lose weight, I would consider that. So to give it to a non-obese person, not that you can't give it, it's an anti-diabetic drug, you can use it. but it's not the ideal situation, and it's expensive. So
yeah, sure. So we come back to Dr. Nilanjan Sengupta. Now, we do have so many fixed drugs combination we have been having for last so many years, and essentially sulfonylurea, metformin, and most commonly pioglitazone, but maybe also voglibose. So one of the planks based on which DPP4s were launched, DPP4 inhibitors were launched, were looking at the potential limitations of sulfonylureas, of which weight gain is one, hypoglycemia is another. Possible cardiovascular adverse effect was another, which is also possibly doubted. But the important point that I wish to bring across is whether you feel that sulfonylureas are actually beta cell toxic. And on that point, do you think DPP4 inhibitors score over sulfonylureas in terms of the effect on beta cells?
Sir, I would like to say it very loudly and reiterate that sulfonylureas are not toxic to the beta cells. They are friendly to the beta cells. They are beta cell secretagogues. And the modern day sulfonylureas stimulate the beta cell less continuously and less strongly than the older ones like glibenclamide or chlorpropamide. But the main point why we do not like to start the treatment with sulfonylurea today, because of the other problems that you had pointed out, that the problems of hypoglycemia and weight gain, and maybe the durability of glycemic control with a single agent. But having said that, we are still using sulfonylurea in our practice. Maybe previously, 20 years before, the treatment is to start with sulfonylurea in the non-obese diabetic and metformin with the obese diabetic, and you add the other and then proceed to insulin. Now there has been a paradigm shift. We are starting with metformin, a DPP4 inhibitor, maybe then consider an SGLT2 inhibitor or a sulfonylurea, or even sulfonylurea as a fourth agent, because type 2 diabetes being a progressive disease, at one point of time, you have to put the patient either on 3 or even 4 drugs, because many patients wouldn't like to be on insulin at that point of time. So the only thing is that maybe we are using sulfonylureas a little later than we were using previously. Glibenclamide and glyclazide are quite safe. They used cautiously, used properly with good education. They should not cause that much of hypoglycemia as we used to see with glibenclamide or chlorpropamide. Even in presence of chronic kidney disease, you can use glyclazide without much dose reduction even. So I think sulfonylureas are there to stay, but they can be used along with the other agents too.
Can I
thank
add
you.
a
Yes,
point,
yes.
Professor
Yes.
Shubham Chaudhary? So just yesterday, I had a patient who was taking as a doctor who had come, and he was taking a lot of insulin 3 times a day. And, I didn't even know why he's taking that much of insulin. We did a C-peptide, fairly good. So I said, you know what, I'm going to add a sulfonylurea to you, and we'll see what happens. Sugars came down so beautifully. I could take him off 2 of his insulin shots and just put him on 1 insulin shot, and good old sulfonylurea worked so well for him, which he had not been taking for some reason. He thought insulin is better or something, and he was taking 3 times a day. So I think I agree with Nilanjan that we should not forget the old ones, that they may not have all the benefits of the new ones, but they're very potent, they're cheap, they've stood the test of time, and they're very safe, and we should not hesitate to use them.
Right. Only the cheap part may possibly cannot be emphasized too much these days with the availability of generic DPP4s and SGLT2.
And the cost of sulfonylurea has gone up for some strange reason. Yeah. I keep saying, why are you raising the cost of sulfonylurea when everything is going down? You give it to the same cost. You give a Mercedes and a Suzuki for the same cost. People will buy Mercedes only, no? So keep that even lower for the common man, for the poor man. Keep something very, very cheap. Give it 50 paisa, 1 rupee. Why do you want to keep on increasing the cost of sulfonylurea? It doesn't make any sense,
Right. Yeah. So I know we've crossed 9 p.m., but maybe we'll wind up soon. We have a few more pressing questions. I hope our panelists will be generous enough to answer them. We come to Manoj. So it's a question from Dr. Deepak Parikh, very interesting, and I think from Intas, Mr. Amit Arora, whoever, this must be food for thought for you as well. Pharma industry has come up with so many FDCs. What about pioglitazone? What about using dapagliflozin with pioglitazone? Any practical advantages, Manoj?
So my first immediate answer to this question is, I like pioglitazone, but it should be by itself, because you have enough issues that come up with pioglitazone. So I don't want the physician fidgeting around with all the treatment. So my first response definitely is, the other FDCs are good, but keep pioglitazone. Like I would say, keep SU outside this thing. Someone pushes me and says, "No, sir, we will put in like this, and it'll, because it's a different mechanism of action and it's the best insulin sensitizer we have." I might give in, just that, okay, go ahead and try it. But my first response, and in today in practice also, I don't like pioglitazone in combinations.
Okay.
And one more thing, let me, in good old days, we used to say metformin causes weight reduction, thiazolidine causes weight increase. So if you combine the two, you will have less weight gain. I don't think that works, but because the mechanism of weight changes are totally different.
Right. Okay. And Manoj, one more from Dr. Sumani. Are we sure that we'll get the same CV benefits with fixed dose combination as we're getting with an individual agent?
Okay, that's an interesting critical question from a research-oriented person. The answer is, I don't know. I expect it to be the same.
Right. And maybe finally, if Dr. Mohan would take it, a question from Dr. Gupta. Which agent do you consider first in uncomplicated, no CV, no renal issues detected, in uncomplicated T2DM, DPP4, SU, SGLT2 inhibitor? It's supposed probably that the patient is already on a metformin and then you're not able to achieve glucose control. So which one do you start after this?
So I look for other comorbidities. So today, is weight a problem? Is hypoglycemia a problem? Is the age of the patient a problem? Do they have other comorbidities? He said no other comorbidities. So age would make a big difference. Suppose somebody is above 70 years of age, I prefer a DPP4 to an SGLT2. Somehow in very old people, I'm not too comfortable using an SGLT2. Although they say it worked better in older people and so on. I'm a little conservative, so I don't use it in very old people unless I'm forced to use it. Similarly, sulfonylurea will not be my choice at an older person. But in a younger person, little bit overweight person, definitely an SGLT2 can be considered. And if the sugar is very high, probably a combination of both also can be used. So I think it depends on the setting. And we have to individualize. And I think this is the beauty of personalized diabetes care. That whatever you discuss in a meeting like this, when the person sitting in front of you, and there may be other things. So for example, if I always tell people you may get a little gentle itching and so on. There are people who just don't want it. They'll say, no, this one I don't want, doctor, give me something else. So I'll give this. If they don't mind and they say it's mild, it'll go away, don't worry. But without telling them, if you give it, it's like cheating them. They end up with things and they don't even know it's due to this. And they'll keep on taking it, suffering all the time. So I tell them, this is the side effect of this, this is the side effect of that. So for the same thing with GLP-1 also, I'll tell them, you will have nausea, you will have this, and this is the way to do it, but it may go off after a month. We tell them everything and then only give the tablet. I think that's being fair to the patient.
Yes, Manoj.
But not in continuation of Mohan's answer, but we were discussing thiazolidine diones and combination. I just want to stress on this fact to the audience that please do not use thiazolidine diones in post-menopausal women because it increases the risk of osteoporosis and fragility fractures. So if you still feel it's a wonderful drug, please use it in the younger generation. to some extent in the aging males, but definitely not in the postmenopausal women.
And we do remember, Manoj, you just now handed over charge as president of ISBMR. Okay, yeah. So I think we had a wonderful discussion this evening on a very important area, and we all know that type 2 diabetes is not just about treating with one drug for the rest of the life. We more often than not, most often we need multiple agents. Eventually, maybe many patients would require insulin, but early use of combination treatment is picking up, and we are trying to learn how best to use it. And we have got some very good combinations from the perspective of combining agents with different mechanisms of action, and also making these work without the risk of hypoglycemia, weight gain, and hopefully also providing them the added advantage of organ protection. So I thank from the bottom of my heart all the three panelists and speakers, Dr. V. Mohan, Dr. Manoj Chadda, Dr. Nilanjan Sengupta, for sparing their valuable time, and all of you. And Mr. Amit Arora usually updates me. So what is the latest count? 1,600 people out there have joined to listen to you, and hopefully are taking back important lessons that will help in turn in their practice, and so many thousands and lakhs of patients in their daily practice. So thank you, all of you, and also all of you who have joined in to make this such a important, memorable evening for all of us. Thank you very much. So now it's back to the organizers for the final comments.
Thank you. Thank you very much, Professor Shubhankar Chaudhary. So it was indeed an intriguing scientific session on role of combination therapy in T2DM. There were plenty of take-home messages, I'm sure, from the talk as well as from panel discussion for all our viewers, which they can implement in their day-to-day practice. So first of all, I would like to express my sincere thanks to our speaker, Dr. V. Mohan, for a very lucid talk on very important subject matter. And it was truly an insightful talk, and I'm sure our viewers must have learned a lot from your talk. My heartfelt thanks to both the panelists, Dr. Manoj Chadda and Dr. Nilanjan Sengupta, for their expert insights, and also for taking up all our audience questions very patiently. For that, I would like to express my sincere thanks to Dr. V. Mohan as well as both the panelists for being generous enough to stay with us beyond 9 p.m. and take up all the questions one by one. We truly appreciate that from our end. And I would like to express my sincere thanks to the moderator of the forum, Professor Shubhankar Chaudhary, for once again excellent moderation and guiding us throughout this forum since the inception. So it was once again a successful scientific meeting, the episode 9. And all the viewers, so I would like to update a number a little bit. It was more than 1,800. So thank you all for continuous support for this Endocrine Talk Show forum. So with this, we would like to sign out of today's meeting. And then
before you sign out, we should thank Intas and all your backend team who have made this happen. Thank you very much.
Thank you. Thank you.
I must thank everyone, my team also, who has put in a lot of effort to bring doctors. And we have the star-studded show today, wherein we have Professor Mohan, Dr. Shubhankar, Dr. Nilanjan, and Dr. Manoj, which actually attracted the doctors to come over on this platform and attend this today's session. So thank you very much from my side to all of you. And of course, the program was sponsored, and we have Dapaval Trio, which is now available at just 19 rupees for dapagliflozin 10 milligram, sitagliptin 100 milligram, and metformin 500 milligram. So 19 rupees for all three drugs you are getting. As Professor Mohan mentioned, that it is all three you are getting less than half of the total cost of the independent drugs. Yeah. so this is the beauty of fixed dose combination. So thank you very much once again from all of us at Intas. Good night to all of you.
Thank you. Very good night.
Thank you. Thank you, sir.